Hello, my name is Sarah Allred. I am a registered respiratory therapist and a trainer with Neonatal Rescue. In this video, we will discuss critical components of the neonatal resuscitation as taught in the neonatal resuscitation program provided by the American Academy of Pediatrics. We will cover the basic process of resuscitation, corrective steps, neonatal oxygenation goals, endotracheal tube placement, and key medications. When resuscitating a baby, the most important thing to remember is that getting air into the baby's lungs is the most effective step in resuscitation. The healthcare provider should ensure that when needed, the baby receives effective positive pressure ventilation. NRP has provided an easy way to remember the basic steps of resuscitation by using the acronym ABCD: airway, breathing, circulation, and drugs. The A for airway reminds us to ensure the baby's mouth and nose are clear of secretions and the baby's head is in a position to open the airways. If the baby is not moving vigorously and is meconium stained, the baby can be deep suctioned. The B for breathing tells us to check for signs that the baby is ventilating appropriately. If the baby is not breathing effectively on their own, the healthcare professional should provide positive pressure ventilation. The C for circulation indicates that compression should be given if the baby's heart rate drops below 60 beats per minute and the baby has received 30 seconds of effective positive pressure ventilation. The chest is compressed 1/3 of the anterior-posterior diameter. 3 compressions are given for every 1 breath in a cycle that is repeated every 2 seconds. The D for drugs recommends that epinephrine be given if the heart rate remains below 60 beats per minute after giving compressions and ventilating for 45 to 60 seconds. It is important to remember that drug dosages vary depending on the route they are delivered. When attending a neonatal delivery, it is important to first learn important information about the mom and baby. Critical information may include the number of babies being delivered, the mom's prenatal history, the color of the amniotic fluid, potential risk factors, and the expected gestational age. The healthcare team should prepare medical equipment and ensure there is a clean area set aside to care for the newborn. After the baby is born, assess the gestational age and their muscle tone. Check to make sure they are effectively breathing or crying. If the baby is term, has good muscle tone, and is breathing well, stay with the mother for routine newborn care. Dry and warm the baby. The baby's head should be positioned to open the airway. Clear any secretions from the mouth and nose if needed. If the baby is not term, has poor muscle tone, or is not breathing well, follow the same procedure while providing additional stimulation to the baby. Stimulation can be provided by rubbing the back or flicking the heels. A baby should never be shaken to stimulate. When the baby is first born, it is normal for the oxygen saturations to be low. At 1 minute after birth, the oxygen saturations are expected to be between 60 and 65%. The saturation should increase as the baby transitions after birth. At 2 minutes following birth, the saturation should range between 65 and 75%. At 3 minutes after birth, the saturation should be between 70 and 75%. Within 4 minutes following birth, the oxygen should be up around 75 to 80%. After 5 minutes, the saturation should be between 80 and 85%. Within 10 minutes after birth, the baby's oxygen saturations should comfortably be between 85 and 95%. If the baby is not responding well to traditional post-delivery care, check the baby for apnea, gasping, or a heart rate below 100 beats per minute. If none of these are present, check the neonate for labored breathing or persistent cyanosis. Ensure the airway is positioned so it is open and clear. Oxygen saturation should be monitored following the chart discussed in the previous slide. Consider using supplemental oxygen or CPAP as needed. Once the baby is stabilized, perform a post-resuscitation briefing with all team members involved. If the baby does initially display signs of apnea, gasping, or a heart rate below 100 beats per minute, provide positive pressure ventilation. Oxygen saturation should be monitored using the chart listed in the previous slide. ECG monitoring may also be considered. If the heart rate is below 100 beats per minute, check for chest movement. If the baby's chest is not rising adequately, perform ventilation corrective steps. These steps will be discussed in the next slide. Consider using an endotracheal tube or laryngeal mask as needed. Poor chest rise is a sign that the baby is not receiving adequate ventilation. If this is noticed, the following steps may be taken. These steps may be remembered using the acronym Mr. SOPA. The M stands for mask adjustment. Begin by trying to reposition the mask. Ensure you have a tight seal and the mouth and nose are both completely covered. The R stands for reposition airway. Place the baby in sniffing position. Make sure the baby's chin is not pressed into their chest and that their neck is not overextended. The S stands for suction. Ensure the baby's mouth and nose are clear of secretions or obstructions. The baby may need to be deep suctioned. The O stands for open mouth. Check to make sure the newborn's mouth is patent. The P stands for pressure increase. Gently increase the amount of pressure being used to ventilate the baby while still being careful not to use excessive amounts of pressure. The A stands for airway alternative. If the current airway is not working to ventilate the baby, consider trying a different method. This may include placing or removing an endotracheal tube. If the baby's heart rate is below 60 beats per minute after performing the corrective ventilation steps, the baby should be intubated. Begin chest compressions coordinated with positive pressure ventilation. 1 breath should be given for every 3 compressions. If available, 100% oxygen should be delivered and ECG monitoring should be initiated. If the heart rate remains below 60 beats per minute, deliver IV epinephrine. Continue to cycle through these steps as needed. If the heart rate continues to stay below 60 beats per minute, consider the possibility of hypovolemia or pneumothorax. 2 key medications are often given during neonatal resuscitation: epinephrine and volume expanders. Epinephrine is often given through an IV, but may also be delivered down an endotracheal tube. When given through an IV, the dosage is 0.1 to 0.3 milliliters per kilogram. When given down an endotracheal tube, the dosage is 0.5 to 1 milliliters per kilogram. Epinephrine should be given rapidly every 3 to 5 minutes if the heart rate is below 60 beats per minute and the baby is receiving compressions. Volume expanders are often given if the baby is in shock. Commonly delivered volume expanders include blood or normal saline. 10 milliliters per kilogram of these medications may be given through the baby's IV over the course of 5 to 10 minutes. The baby should be assessed following each given bolus. When a neonate is intubated as part of the resuscitation process, the tube size and the depth placement depends on the age and the weight of the baby. If the newborn is less than 28 weeks old or weighs less than 1.0 kilograms, a 2.5 millimeter tube should be inserted and secured at 6 to 7 centimeters at the lip. A neonate between 28 and 34 weeks old or weighing between 1 to 2 kilograms should have a 3.0 millimeter tube placed and secured at 7 to 8 centimeters at the lip. A 34 to 38 week old newborn or a baby weighing between 2 and 3 kilograms should have a 3.5 millimeter tube placed and secured at 8 to 9 centimeters at the lip. A neonate greater than 38 weeks old or weighing more than 3 kilograms should have a 3.5 to 4.0 millimeter tube placed and secured between 9 to 10 centimeters at the lip. One simple way to remember the estimated depth of insertion is to add 6 to the baby's weight in kilograms. It is important to recognize that these measurements are guidelines, and the individual baby's needs may vary. This concludes some neonatal resuscitation critical components as described by the American Academy of Pediatrics and the Neonatal Resuscitation Program. Thank you for your attention. You may reach us by sending an email at training@neonatalrescue.org.